Welcome to another episode from the Veterinary Research Channel. Today, we delve into a fascinating and rare case encountered in veterinary medicine, ureteral duplication in a French bulldog. This condition, where a dog has more than one ureter on a single side, is not often seen, with only a handful of documented cases. This particular case, successfully treated, offers valuable insights into the diagnosis, management, and potential outcomes of this unusual anatomical variation. Our story begins with a 7-year-old female French bulldog who presented with a concerning set of symptoms: anorexia, vomiting, and a purulent vulvar discharge. Initial examinations led to a diagnosis of pyometra, a uterine infection, which was addressed through an ovariohysterectomy, a surgical removal of the uterus and ovaries. The procedure was seemingly successful, with no immediate complications or other apparent abnormalities detected during the preoperative workup or the surgery itself. However, the relief was short-lived. A mere 13 days post-surgery, the concerning purulent vulvar discharge reappeared, now accompanied by stranguria, or straining to urinate, and polyuria, the frequent urge to urinate in small amounts. This recurrence prompted a follow-up visit, where physical examination confirmed the persistent vulvar discharge. Blood work remained within normal limits, but a urine sample revealed the presence of leukocytes and red blood cells, indicative of a urinary tract issue. A urinary culture identified Staphylococcus pseudointermedius, a bacterium, as the culprit. What was particularly noteworthy was that this bacterium was sensitive to a range of antibiotics, including amoxicillin clavulinate, the very antibiotic used in the initial treatment. Further investigation was clearly warranted. An abdominal ultrasound was conducted, revealing a long, dilated structure, approximately 2 centimeters in width, located near the bladder and cervix. Initially, there was suspicion that this structure might be an abscess of the residual cervix, a complication sometimes seen after a hysterectomy. Consequently, a course of medical management was initiated, including amoxicillin clavulanic acid, an antibiotic, meloxicam, an anti-inflammatory, and fluoroglycinol and trimethylfluoroglycinol, medications aimed at relieving spasms. Despite this medical intervention, the dog's condition remained stubbornly unchanged. Stranguria and polyuria persisted, and repeat abdominal ultrasound examinations showed no improvement. This lack of progress prompted a computed tomography, or CT, scan. The CT scan revealed a large, tubular, fluid-filled structure connecting the pelvis area of the right kidney to the bladder. Intriguingly, this structure closely paralleled the right ureter, the normal tube that carries urine from the kidney to the bladder. Even more telling was the fact that post-4 contrast images, known as 4 urography, failed to demonstrate a functional connection between the renal pelvis and this dilated tubular structure. In simpler terms, dye injected into the bloodstream didn't flow into this abnormal structure, suggesting it wasn't actively participating in urine transport. The normal left and right ureters, in contrast, did display contrast within their lumens, confirming their functionality. At this point, surgical management was recommended. However, the owner initially declined, leading to an extended course of antibiotic treatment with trimethoprim sulfamethoxazole over 5 weeks. Unfortunately, this medical treatment failed to yield significant improvement. It was 4 months after the initial ovariohysterectomy when the owner finally agreed to surgical exploration. Pre-surgical abdominal ultrasound examination and CT re-examination were unchanged when compared to previous results. Before proceeding with surgery, a vaginourethrocystoscopy was performed. This procedure involves inserting a small camera into the vagina, urethra, and bladder to visualize these structures. The examination did not reveal any relevant findings in the urethra, bladder, or vagina. Both ureter papillae, the openings where the ureters enter the bladder, were found in their normal positions. With the dog under general anesthesia, a standard median laparotomy was performed. This involves making an incision in the abdomen to allow for direct visualization and manipulation of the abdominal organs. The surgical exploration revealed a tubular mass measuring 19 centimeters in length and 2 centimeters in width in the retroperitoneum, the space behind the abdominal lining. This mass extended from the cranial pole of the right kidney to the bladder neck. A small cystotomy, an incision into the bladder, was performed to facilitate antegrade urethral catheterization, the placement of a catheter into the urethra from the bladder. An incision was then made in the retroperitoneum over the right kidney, revealing a macroscopically normal kidney except for the cranial pole, where the tubular structure connected to the renal parenchyma, the functional tissue of the kidney. The structure was intercapsular but appeared to culminate as a blind pouch within the renal parenchyma. Along its retroperitoneal course, the right ureter and the dilated structure were adjacent, but entirely separate. At the other end, the structure entered the right side of the bladder wall near the trigone, the triangular region at the base of the bladder. At this point, it appeared to have an intramural course, extending further caudally on the bladder neck and ending in a blind lateral and dorsal pouch. The resection of the tubular structure was carried out from the kidney, close to the renal cortex, leaving the blind pouch open, and to the bladder wall, without removing the intramural pathway. Bacterial culture was performed on the luminal contents of the duplicated ureter. Because of the close proximity between both structures, the normal ureter was also dissected from the retroperitoneal space without damaging the cranial and caudal ureteral arteries. The remaining intramural tunnel was probed with a urinary catheter, which followed a short intramural course before exiting the bladder wall to end in a dorsolateral pouch close to the bladder neck and the urethra. This blind pouch was opened, revealing no clear communication with the bladder lumen, residual cervix, or vagina, although it may have continued further with an unseen small communication. After resection of the tubular structure, the blind pouch of the right kidney and the intramural course of the bladder wall were omentalized. This involves wrapping the omentum, a fatty tissue within the abdomen, around the surgical sites to promote healing and prevent complications. The abdomen was closed routinely following a thorough abdominal lavage. Normal urination was observed immediately after the procedure, and the dog was discharged 2 days after surgery with amoxicillin clavulinate and meloxicam. The histopathology analysis of the resected structure confirmed that the sample displayed the microscopic morphology of the ureter wall, leading to the final diagnosis of a duplicated ureter. It consisted of a tubular structure lined by a transitional epithelium and underlying lamina propria and an outer circular layer of smooth muscle, modified by interstitial fibrosis. Intraepithelial leukocytic cytosis, mainly composed of neutrophilic granulocytes, and subepithelial lymphocytic and plasmacytic infiltration of the superficial lamina propria were observed. The lumen was filled with degenerated neutrophils and contained numerous bacterial colonies. Bacterial culture revealed the presence of the same bacteria as previously identified, S. pseudointermedius, which remained sensitive to amoxicillin and clavulanic acid. 2 weeks after surgery, the dog had completed her medical treatment and exhibited a complete resolution of all previously mentioned clinical signs. On abdominal ultrasound examination, the right kidney appeared nearly normal, with a residual 5 mm hyperechogenic structure within the cranial part of the cortex corresponding to the omentalization site. In addition, the right ureter appeared normal with no signs of stenosis or dilatation. Serum biochemistry analysis indicated normal urea and creatinine concentrations, and urine analysis, including bacterial culture, revealed no sign of urinary tract infection. During the second follow-up, conducted 6 weeks after surgery, the dog remained in good health with no reported abnormalities. Abdominal ultrasound examination and serum biochemistry analysis were unchanged. At a long-term follow-up performed 11 months after surgery, the owner reported a favorable clinical outcome with no recurrence of clinical signs. This case highlights several important aspects of ureteral duplication. First, it underscores the variability in clinical presentation. While urinary incontinence is a common sign in animals with duplicated ureters, this dog presented with purulent vulvar discharge, polyuria, and dysuria. The absence of urinary incontinence initially may have made the diagnosis more challenging. Second, it emphasizes the importance of advanced imaging techniques in diagnosing this condition. While ultrasound can provide clues, CT with contrast is invaluable in delineating the anatomy of the duplicated ureter and assessing its functionality. In this case, even with a combination of ultrasound, CT with contrast, and vaginoscopy, precisely describing the anatomy of the duplicated ureter before surgery proved difficult. The authors suggest that a retrograde urethrography, an X-ray of the urethra after injecting contrast dye, could have aided in identifying any potential distal implantation of the duplicated ureter. Third, the case illustrates the challenges in managing ureteral duplication. There is no one-size-fits-all approach, and treatment must be tailored to the individual animal. Options range from medical management to various surgical procedures, including nephrectomy, ureteroneocystostomy, nephroureterectomy, and, as in this case, removal of the duplicated ureter. The decision to perform a subtotal ureterectomy, leaving only the distal portion of the ureter, was based on the fact that the duplicated ureter was deemed non-functional and blind distally. The omentalization of the proximal and distal ends of the ureter was a strategic choice to preserve the integrity of the bladder wall and conserve renal parenchyma. Finally, the case raises questions about the pathogenesis of the infection in the duplicated ureter. Since there was no clear communication between the blind ureter and the urogenital system, the exact route of infection remains speculative. Ascending infection, hematogenous translocation, or direct bacterial contamination through the bladder wall are all possibilities. Regardless of the mechanism, the removal of the duplicated infected ureter appears to have eliminated the source of the persistent infection, leading to the resolution of clinical signs. In conclusion, this case report provides valuable insights into the diagnosis and management of a rare condition, ureteral duplication, in a dog. It highlights the importance of considering this anomaly in cases of persistent vulvar discharge and urinary issues, even in the absence of urinary incontinence. It underscores the utility of advanced imaging and diagnosis and the need for individualized treatment plans. The successful outcome in this case demonstrates that surgical resection of the duplicated ureter can be a viable option, leading to complete resolution of clinical signs and a favorable long-term prognosis. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.